Good morning, everyone. Thank you for being here. My name is Marino Sotiropoulos, and on behalf of the Chief Residents, I'd like to welcome today's Grand Round speaker. So there are some renovations going on at the Ether Dome, so we're only virtual today. Today we'll be hearing from, exceptional, well-known physician scientist. It's also one of our beloved attendings, Dr. David Perez. David graduated from Columbia University and then from NYU School of Medicine, and then trained in both neurology and psychiatry at our local Harvard programs here. And then he went on to found the Functional Neurologic Disorders unit and the FND research group at MGH, which he's been heading for many years. He's associate professor of neurology and associate professor of psychiatry. He's our new chief of the division of behavioral neurology and integrated brain medicine. And of course, he's a world expert in functional neurologic disorders and in the interface of neurology and psychiatry and how they can learn from each other and work better together. He's published more than 140 papers and multiple textbooks. He is the president of the Society for Behavioral and Cognitive Neurology and the current chair of the AAN section of the Behavioral Neurology and Neuropsychiatry. Thank you so much for being here, David, and for sharing your talk with us. So David is going to be talking about what neurology can learn from FND, clinical, neurobiological, and programmatic insights.
Marinos, thank you for that very kind introduction. It's wonderful to be here with everyone. Certainly a touch bummed that we're not together in the Ether Dome, but we live in a virtual world, and so we're certainly going to make the best of it with this conversation. Let me share my slides, making sure I share audio as well. Just give me 1 or 2 seconds here to set this up. Okay, and Marinos, can I just get a thumbs up that you hear me okay and my slides are up?
Yep, it's perfect.
Okay, wonderful. So I'm thrilled to be here. I'm energized to be visiting with all of you. And I want to set the frame a little bit. So I've designed a new talk today. I'm not speaking today on our journey in elucidating the structural and functional biology of FND over a decade plus, or even thinking a little bit about how we clinically use our neurologic, psychiatric, and rehabilitation skill set to assess and manage this population. What I am speaking about today are work in progress research efforts, hot off the press research efforts, and also some points of collaboration with international colleagues, where much of that work is actually happening elsewhere. But I think we're primed for taking some of that work and also having it grow into major research questions here with us. These are my disclosures. And I would like to begin as we think about discussing together functional neurological disorder. I'm going to use the abbreviation FND. This is a condition that challenges us to think about how do we conceptualize neurologic disease? How do we conceptualize psychiatric conditions? Are there points of intersection? Frankly, many. Should we be thinking primarily about this notion of complex brain-based disorders? And as we think about health, right, we oftentimes have these conversations about brain health, physical health, mental health. Maybe we're just talking about health in general as well, and the many points of intersection between mental health and physical health. So here is a visionary statement from Stanley Cobb. There is no problem of mind versus body, because biologically, no such dichotomy can be made. The dichotomy is an artifact. There is no truth to it. And the discussion has no place in science in 1943. Really forward thinking. I would argue that in 2024, we've yet to fully realize this vision, but we're certainly getting there. Now, as we talk together about FND, I think it's really important to think about the full spectrum of functional neurological disorder. So this includes patients with a range of motor and movement presentations, paroxysmal events, what we call functional seizures, disturbances in speech and voice, this new entity of functional cognitive disorder that I'm going to spend some time talking to you all about today, functional sensory deficits, and persistent postural perceptual dizziness. So really broad spectrum, each with their rich literature. Just a pause for a moment. I think there's a couple people maybe on mic, and maybe Marinos can help mute them. Thank you. The other piece to highlight is that many patients have mixed symptoms. This is particularly true across the motor, seizure, speech, and cognitive spectrum. Okay, so maybe adding to the list, functional neurological disorder with mixed symptoms being highly prevalent. And this is also part of the rationale for clinical and research programs to cut across a range of subtypes. So today's task together, I'm going to first focus a bit on the epidemiology and health economics of F&D for some updates. So if you work in neurologic care settings broadly, outpatient clinics, the emergency department, inpatient wards, you see patients with functional neurological disorder. And we now have a range of convergent data internationally that F&D is likely among the top 5 reasons for patients to be referred for an outpatient neurology consultation. Really staggering numbers. There's quite a bit of work to be done to further operationalize the incidence and prevalence of F&D, and this is actually work that Sarah Finkelstein is currently leading in collaboration with colleagues in the UK. And so stay tuned for much more on how we think about the incidence and prevalence of F&D in 2024. The other piece is, given that we encounter this across healthcare settings, we know that F&D rivals many other major neurologic and psychiatric conditions that we encounter. Chris Stevens put this on the map in a really nice operationalized way in his JAMA Neurology paper in 2021, where he looked at health economic data up until 2017. 1.2 billion spent annually in the emergency department and inpatient care for F&D. But we have an update. So this is work currently under review using now data up to 2019. $2 billion are spent annually in the emergency department and inpatient care of this population. It's adjusted for inflation. Also, the rate of change at which costs are escalating in F&D seems to be outpacing several other neurologic populations that are quite pharmacologically intensive. Here's the other piece. In proportion to healthcare expenditures, extramural NIH funding is really lagging behind in F&D. And Chris has been astute in putting a nice spotlight on this paper that recently we received
I just texted you.
the initial review for, and we've been invited to resubmit. So stay tuned. But we're continuing to really advocate that not only is this prevalent, not only is it costly, but frankly, it's a problem to invest in for a number of reasons, and we'll cover some of that as well. Okay, so now for the next few slides, I really want us to think together about a new entity that's been operationalized in 2020, functional cognitive disorder. And here I'm really going to highlight work from the University of Edinburgh and the University of British Columbia. So a bit of background for all of us. So back in 2020, a range of international colleagues, predominantly overseas, sought to operationalize a cognitive variant of functional neurological disorder termed functional cognitive disorder. So here patients have cognitive complaints, and the hallmark or rule-in sign are features of internal inconsistency. We're going to talk about that, right? That's sort of key because it's yet to be fully operationalized. And you want symptoms to not be better explained by other medical, neurologic, or psychiatric conditions. Obviously, the cognitive symptoms have to be impairing socially or occupationally. So, internal inconsistency. What is it? And so a definition. Internal inconsistency is the ability to perform a task well at certain time points, but with significantly impaired ability at other instances, particularly when attention is drawn to the task. Let's think about memory clinics. Those of you seeing patients with amnestic MCI or early stages of Alzheimer's disease, you may ask the patient how they're doing. Are they struggling with aspects of their cognition or memory? You may find that they're largely devoid of complaints. They may say they're struggling a bit, or maybe even they recognize they're struggling quite a bit. That level of awareness, unfortunately, is lost over time. But they really do not give you exquisite detail about memory failures and all the instances in which it's coming up. So prominent memory trouble with an exquisite reporter without using notes, providing eloquent, well-organized detail. This is a feature of internal inconsistency. You can also think about features of internal inconsistency in relation to neuropsychologic testing. Okay, so for example, let's think about working memory task. Paradoxically performing better in a digit span backwards task than a digit span forwards, right? You need the cognitive machinery to hold on to the basic information and manipulate that information. And if you can do that, but can't do the first step, that's a bit of a paradoxical finding. You can think about the same thing with impairments in registration versus short-term memory recall. And there's quite a bit of work to be done, I would argue, at the level of interview, bedside testing, and neuropsychologic testing to really operationalize features of internal inconsistency that are specific and sensitive for this population. So that's really not been done yet, but it's work in progress. Now, let's take this conversation and put the patient front and center. This is a patient who received treatment by our psychologist, Dan Milstein, during his fellowship at an outside institution. But when he came to us, we were fortunate enough to help him publish this case. So first, the symptom description.
I had trouble remembering things. I would lose data. I couldn't remember words. Speaking got very difficult, things like that.
And some reflections on the diagnostic journey.
It took about 4 years for this to be accurately diagnosed. So the first thing was to get a diagnosis and to actually have a neurologist who said part of your treatment should be that you talk to a neuropsychiatrist or a neuropsychologist, and that to tell me, like, that is just part of what we need to be addressing. And it made perfect sense to me that it was, the more I've looked at it, that what happens in my brain affects what happens to me physically in very kind of, at the time, very scary ways, but I didn't understand that it started here and was manifested physically. So I think having help physically with the physical therapist, and you was saying, like, there's this whole other part of your brain that we need to think about that's contributing here.
This is obviously a patient who's reflecting retrospectively on the therapeutic journey, quite insightful. And here are some more reflections on lessons learned.
Okay, a real quick anecdote. I had a lot of stress. My parents were very ill and aged. They have since passed. And every time I drove to their house, the closer I would get, the more I would just start to shut down. And I didn't really realize that it was happening. And I'd sort of get closer and closer. And one day my husband was driving and I had just talked with you and you had said, just feel them, just experience your feelings and feel them like they're valid. So I just let myself feel really stressed and I went through it and I felt it and then it was gone. And it was like this, it had happened. I couldn't really explain. I just felt so much better. Like I guess I had never let myself really feel how I was feeling.
This patient received a form of psychotherapy called emotion-focused psychotherapy, which is a form of psychodynamic psychotherapy. Sorry about that. I will add that predominantly our group uses skills-based psychotherapeutic approaches, as well as a range of rehabilitation techniques. And, you know, patients come to us with a high degree of complexity, oftentimes with symptoms where the robust clinical trials haven't yet been performed. And we think about, well, what's available in our playbook? And how do we modify our playbook to help the patient who's sitting in front of us? And here in this write-up, Ellen Godina shared with readers our modified skills-based psychotherapy playbook to help a patient with functional cognitive disorder, a distinct patient. And we also shared how teaming up between a psychotherapist and another rehabilitation expert, in this instance, a speech and language expert, Jennifer Freeburn, how forms of cognitive retraining can also be helpful for functional cognitive disorder. We're quite keen to operationalize this effort and hopefully engage in some prospective clinical trial work as well. So zooming back out though, this entity of functional cognitive disorder, where are we in 2024? It's been operationalized several years ago. And here, colleagues in the UK, including Veronica Cabrera and Alan Carson, recruited 45 cognitive experts. I was fortunate enough to participate as one of those experts. And in a several-part study, one of the parts was to have a range of experts review clinical vignettes to comment on their diagnostic impressions, as well as their impressions of what's required for an initial clinical assessment. And a portion of the findings now published in the European Journal of Neurology is that, maybe no surprise, there was quite a bit of agreement for vignettes that were quite classic in their presentation for neurodegenerative disorders, Alzheimer's disease, primary progressive aphasia, among others. Maybe also no surprise, there was a lot of disagreement about vignettes that were drafted to represent functional cognitive disorder. What do people call it? Do they call it mild cognitive impairment? Subjective cognitive impairment? This is cognitive impairment driven by mood and anxiety. Or are they using this label functional cognitive disorder? And you can see highlighted in the blue squares a fair amount of heterogeneity there. In a second wave effort here, in a paper currently under review, this group engaged the same 45 experts, now thinking, can we develop a checklist? Can we operationalize a signpost for people to at least ask the question, might this patient in front of me meet criteria for a functional cognitive disorder? We went through a modified Delphi approach. It was quite involved. Ultimately, a long form diagnostic checklist with 11 items was developed, as well as a short form. And you can see here on the screen some of the items. So I'll read a couple of them. And these are items filled out by the clinician. is there a discrepancy between the level of symptoms reported and everyday function, particularly a really big mismatch, right? Marked impairment being reported in terms of cognitive and memory trouble. Yet objective evidence being verified, they continue to perform very well in a demanding job. Item 2, is the patient able to detail specific examples of memory complaints or memory failures? And that was getting at this notion, again, of internal inconsistency. There are various other items. They also sought to see how this checklist might perform in everyday clinic populations. They did this retrospectively across a number of clinic sites. And what they observed is that a cutoff score of 6 out of 11 had 97% specificity in identifying cases of functional cognitive disorder in comparison to a range of other conditions. You can see those labeled there. This is very much a work in progress, including I've been a bit critical that we don't want to conflate all cases that are multifactorial, non-neurodegenerative etiologies of cognitive trouble with functional cognitive disorder. But we see this, and we see this clinically in a number of patients, particularly those presenting midlife. And there's now going to be a future effort to look at this checklist and its performance prospectively. So stay tuned. And actually, before I transition to the next part, it's really to highlight that in memory clinics, the data suggests about 1 in 4 patients who are being evaluated in memory clinics do not have a neurodegenerative disorder. So that really says that that subpopulation of patients are really primed for potentially a different kind of clinical pathway for assessment and treatment. And we can ask the question, do at least a subset of those patients have a variant of functional cognitive disorder? Okay, similar segue is this notion of how do we think about patients with persistent symptoms post-concussion? Let me pause here first and provide a really important disclaimer. Like my opinion about functional neurological disorder, which is that it's mechanistically and etiologically heterogeneous, okay? There are not one-size-fits-all formulations. There may be subgroups and pockets when we can think about this. I have the same opinion about individuals who have persistent symptoms post-concussion. This is mechanistically and etiologically heterogeneous. It's also really interesting that this is relatedly another population that has a high degree of biopsychosocial complexity. And many different groups now internationally are asking the question, is at least a subset of patients with persistent symptoms post-mild TBI, post-concussion, are they representing a variant of F&D, including a variant of functional cognitive disorder? We don't know, but this is very much work that's being done by several groups, including work by Noah Silverberg, a neuropsychologist in Canada, maybe familiar to some in the audience as he was at Spalding in 2017, 2018, which is where we first became acquainted. And in this study here, his group recruited 77 individuals, okay, with moderate to severe persistent post-concussion symptoms. They're over 10 weeks out post-injury, okay? And he asked the question, cross-sectionally, what baseline psychologic, neuropsychiatric characteristics might co-vary with unexpected neurologic symptoms in this population? What are unexpected neurologic symptoms? Endorsement of limb weakness, stuttering speech, loss of voice, right? The kinds of symptoms we see potentially in functional neurological disorder. And in univariate and multivariate approaches, one of the constructs, and the construct that was particularly associated with persistent unexpected neurologic symptoms, was this construct of fear avoidance behavior. So what is this? Fear avoidance behavior is actively disengaging from behaviors that are seemingly thought to trigger or exacerbate physical symptoms. Okay, this is common sense, right? We should all do this acutely. The issue is that if this type of avoidance behavior is done chronically, it has a range of unintended consequences and itself becomes a perpetuating factor. This kind of construct is also the construct that is targeted, among others, in skills-based psychotherapy. Another construct that Noah and colleagues were interested in exploring is potential relationships between how does one perceive their cognitive abilities, particularly pre-injury, this notion of pre-injury factors, and what might be the relationship between these trait characteristics and the endorsement of severe memory trouble post-concussion. So this is the exact same cohort as the past slide, but now they're looking at associations between those who reported severe memory trouble on a concussion forgetfulness item versus those who did not. And the association that they found, adjusting for a range of potential confounds, including depression scores, is this notion of a tendency towards memory perfectionism. It's important that I'm very accurate when remembering the names of people, one of the items. I think a good memory is something of which to be proud of. And in qualitative interviews done by other groups, when they interview patients who ultimately have a diagnosis of functional cognitive disorder, they tend to retrospectively report that they always had really sharp memory, being able to remember everything that came up in their day-to-day. You know, a pause in our 2024, gosh, I'm happy to say that my executive function is at its limit, and that, you know, at times I misremember and forget. And that just may be a bit of the sign of the times and how much we're having to navigate. But these trait characteristics, how do you perceive yourself currently? How do you perceive yourself in the past? How does that self-perception from the past relate to how you're contextualizing your physical symptoms now? These are some of the complexities that are very relevant for persistent symptoms post-concussion, including the possibility of functional cognitive disorder. Okay, so before transitioning, it's really a pause that these populations are ripe for deep inquiry of the kind that is being started and led by several other groups. Okay, let's transition now to some of our ongoing neuroimaging efforts in functional neurological disorder. And by design, this is a mixed F&D, in particular cutting across the spectrum of functional motor and functional seizures. But before we do that, let's again think about the patient's clinical journey. This is a patient who's been generous. They've allowed us to record these videos. They presented symptomatic to a research visit. And this presentation of functional facial dystonia with speech difficulties can occur in isolation or can occur coupled to a functional seizure or coupled to a functional weakness event, really showing mechanistically how overlapping these functional neurologic symptoms are. And so the symptom description.
Describe for me, what are you experiencing right now?
I think I'm emotional because my speech is off and my face is very hardly twisted.
Now, the day of this research visit, it was a rainy day in the city of Boston. And so that'll help you understand a bit of this context.
And the guy says, this happened before. He says, I don't have the name, like I'm lying. Anyway, before that happened, I had another incident. I went into the wrong door, and the door was open on the side. And the security said to me, "How did you get in here? Like I'm like a criminal or something." I said, "Well, the door was open, and I came in. I had to get out of the wet because it was so pouring out." And I think that could have escalated the FNG episode because it stressed me out. And he says, "Oh no, go down this way," and it's okay because I think he saw maybe that I was upset.
You can even notice there, I had to get out of the wet, which asks you the question to think about functional language disturbances. Now, 1 or 2 minutes later, this whole series of clips really were captured over under 5 minutes. And what helps?
FND now.
I think I'm a professional. I understand how it ticks. I wish I could get rid of it. That would be the greatest thing, but it's something I have to live with. So I have to have my tools to make this not so severe and come out of it faster. Before, I couldn't come out of it faster because I really didn't know what to do. And the first thing people say, "Oh, don't talk, because it's going to get you more excitable and more nervous and do it." Actually, that's the total opposite. Talking helps to tell people and to understand what FND is. And then the face starts to come back up and the face starts to relax.
And the skills, by the way, that this patient's alluding to include skills-based psychotherapy, as well as some really robust and nice work working with our occupational therapy colleagues. Okay, so the first project and the question, are structural brain MRI features useful in attempting to predictively classify a functional neurological disorder? This is work recently published a couple of months ago, led brilliantly by Christy Westland and Andrew Guthrie in my lab, and really has involved a number of people who have contributed really well to this project. It's 5+ years in the making. Okay, so a bit of background. Functional neurological disorder with a capital F, right? We frame this as a brain network communication problem, one of functional brain networks. And yet, if you followed our research, right, we actually began with quantitative structural imaging and investigating brain symptom severity and brain prognosis relationships in this population a number of years ago. We did that because it was a gap. And certainly also structure and function are exquisitely coupled in the brain, right? We can think about orders of scale. Is FND a macroscopic structural problem? Is there a space occupying lesion? Okay, the answer is no. But at the microscopic level, quantitatively, certainly if there are persistent functional neurosignatures, then one would argue that there are relevant structural features as well. Yet, also the findings have been heterogeneous, right? They implicate brain regions that are part of the salience network, default mode network, attentional networks, sensory motor networks, okay, but they're patchy. Sometimes they're even in different directions. And the analyses have largely focused on group level approaches using univariate techniques. How might we do this differently? Well, there isn't likely one brain area or one part of a brain area that is really critical for developing and having persistent functionologic symptoms. It's likely really subtle structural features and its relationships between many different brain areas, this notion of multivariate approaches. And can we also push the boundaries and say, look, ultimately we want this biological research to be clinically relevant. So we have to think about individual level predictions. One way of doing this is using supervised machine learning, and in particular, support vector machine, just to give those of you who aren't used to thinking about these approaches day to day a bit of background here. So we're training the computer to identify multivariate features that appear to be associated with people that we pre-specify and label as those in the population in this cohort that have a diagnosis of FND. We similarly train the machine to identify features that appear to be associated or covarying in a multivariate way with another subgroup. In this case, for example, healthy controls. Can the software identify a multivariate boundary that distinguishes FND versus healthy controls? And then can you introduce a new data point without a pre-specified label? And can it sort it out? And can it sort it out accurately? Right? This is the process that's happening here. So the cohort, 183 participants. We recruited prospectively 61 with FND. You can see 46 have functional motor presentations, 23 have functional seizures, 8 of those have both. Again, maybe no surprise. We have age and sex matched healthy controls. And really importantly, we have age, sex, depression, and anxiety score matched psychiatric controls. These are people with clinically salient anxiety, depression, and/or post-traumatic stress disorder recruited from the community. We're using FreeSurfer-based software developed here at the MGH Martino Center, and you can see the features, specifically cortical thickness and a range of subcortical volumes. We're using support vector machine classification with tenfold cross-validation. One can validate with cross-validation, or one can validate with an external independent cohort. We've not yet done that, but that's certainly one of our next steps. So within this set of cohorts, our classification results. Let's first begin with the largest sample, mixed FND. How do we do against healthy controls? You can see the data here, and we can accurately predict about with 66% accuracy, patients who identify patients who have FND versus healthy controls. The performance metrics are moderately good. They're not perfect, but 0.74 is quite reasonable. Let's think about mixed FND versus psychiatric controls. Yes, we reach statistical significance. The accuracy is 60%. Here, the performance metrics drop quite a bit, 0.56. This is fairly limited performance metrics. And maybe no surprise, because psychiatric controls have both structural and functional problems that relate mechanistically to their diagnosis. Also, there are many shared commonalities between FND and our psychiatric control population, though none of the people in the psychiatric controls have functional neurologic disorder. How about subtypes? Might subtypes be a more homogeneous sample? And here I'm going to just show you all the data. And in particular, when we look at our largest subtype, the functional motor subtype versus healthy controls, 72% accuracy, but most notably, I think clinically, is interestingly 0.83 specificity in having the machine differentiate functional motor versus healthy controls simply by MRI features. Let's take a slight deeper dive. You can see here the confusion matrix, as well as the area under the receiver operating curve. They look, quite reasonable, not perfect, and certainly room for improvement, but a real conversation starter in this notion of big data and classification. And let's think biologically. So what features were, and predominantly what we observed is that a range of features that encompass portions of the hippocampi, the cingulate gyrus, the amygdala, were over and over again the most important features in a multivariate framework for classifying F&D versus healthy controls. Let's zoom out a bit more. So across all the analyses, what also caught our attention is if you can identify the posterior cingulate, and in particular the isthmus cingulate, you'll find that the isthmus cingulate is colored in kind of a dark orange across a range of analyses. It's at times bilateral as well. And the posterior aspects of the default mode network are increasingly being identified as potentially being important in disturbances in dissociation and the fragmentation of how one processes sensations in their body. This will lead us in the future to think a little bit more about points of intersection between F&D and the mechanisms of dissociation. Now, what influenced classification? So it turns out that we ran a number of post-hoc analyses to look at this. There were trend level associations between those who had been sickest the longest, had a slight tendency to be more accurately classified. You might think about if the structural findings are disease related or even compensatory, right? That more time being ill might allow some of those differentiating features to obtain the characteristics that allow the software to more accurately classify. But correcting for multiple comparisons, actually none of the features that you see on the screen impacted classification, including sex differences or depression, anxiety, childhood maltreatment. Implications here, as we think about these large-scale efforts, right? These predictive algorithms for raising our index of suspicion for one diagnosis or another. And by the way, I'm far from a proponent for the computer replacing any of our expertise. But ultimately, if large data is being funneled through multivariate with a range of considerations, and they're coming into the clinic with potentially a printout, or you receive a printout to say, this patient, keep a radar for these range of considerations, they might be clinically relevant here, right? Allowing the clinician to both keep an open mind, but make sure that any blind spots are shored up, as this work really needs to become much, much larger scale. I think what this argues is, let's not just focus on task-based activation or resting state functional connectivity. That structural brain features matter in F&D too. Now, the implications of what we found, also, it's not yet clear, right, how intrinsically related to disease mechanisms some of these multivariate relationships are. We have longitudinal data collection ongoing, and as we think about data points that co-vary with symptom severity over multiple time points or co-vary with clinical improvement, that may allow us to really approximate in a more targeted fashion, well, what exactly is happening here, right? The other piece is relationships are nuanced. I'm humbled. Yes, we're doing hypothesis-driven research, but ultimately, when we're looking for a multivariate boundary across 134 features, right, I can't develop that hypothesis. So this is really where machine learning algorithms are really at the forefront, and they can help us. Project 2, yes, F&D is a functional network problem as well. And this has been shown by a number of studies using healthy controls. And I and others have put in writing that F&D appears to be a problem of abnormal crosstalk within and across multiple brain networks. But what's the data for that? and have studies actually looked at canonical brain networks and asked this question rigorously in an operationalized fashion? And the answer is it hasn't quite really been done. And it certainly hasn't been done against psychiatric controls. So in this work that we're really in the lab right now, analyzing and soon to write up, we're asking the question, is F&D predominantly a problem of abnormal communication across brain networks? Is it abnormal crosstalk within one or more brain networks? Or is it a problem of both? So here we have the same sample that I've just made reference to, some slight modifications in the numbers, in part also because we're looking for head motion and the kinds of pre-processing factors that might require us to exclude a handful of subjects. Very importantly, our psychiatric control group, which I'm going to focus on the F&D versus psychiatric controls for these next few slides. They're matched to our F&D group by age, sex, head motion, depression scores, state trait anxiety, and PTSD severity. So they're really well matched. And we're asking the question about the 7 canonical networks listed below, operationalized by Yale et al. In 2011. And the method that we're using is a form of graph theory. And I want to give a nice acknowledgement both to Christy Westland, who's leading this effort, as well as our close collaborator, Ibai Dez, who's provided expert opinion on the methodologic side. And we're testing these notions of integration and segregation. So let's define them here. Integration. When we look at voxel to voxel connectivity, does the voxel to voxel connectivity begin in one resting state network and end in a different resting state network? If so, that link, that voxel to voxel connectivity, is characterized as an integration link. It cuts across 2 networks. Segregation is the opposite. Does that voxel to voxel connectivity begin in one resting state network and end in the same resting state network? And these architectural relationships, we're then asking the question, at the level of integration links and at the level of segregation links, are there differences in F&D versus psychiatric controls? And if so, where are those differences? So here are our work in progress findings. And across analyses that are done at the whole cohort level, mixed F&D versus psychiatric controls, or at the subgroup level, motor F&D versus psychiatric controls, or functional seizures versus psychiatric controls. One of the patterns, or a set of patterns that we observed across a range of findings, was increased cortical integration in several brain areas that are engaged in somatomotor function, and they're part of the somatomotor network. These findings, by the way, hold for age, sex, antidepressant use. They hold, again, for adjusting for psychiatric scores. And they also hold for risk factors like childhood maltreatment. Findings are whole brain correct. So if we think about crosstalk between networks, the next question is, well, what's happening here? So we took the peak voxels, left hemisphere and right hemisphere, in these integration-related functional connectivity findings. And what we find is an intrusion or abnormal crosstalk with a range of other functional connectivity networks. Default mode, frontal parietal, ventral attention, also known as salience. You can see that for the top seed and the bottom seed. So it's as though, and this is speculative now, that sensory motor function seems to be hijacked by attentional and arousal and introspective and threat-related mechanisms, driven in part by functions that relate to those resting state networks. Again, speculative, but this hijacking notion and the intrusion really fits well with what we see, including this notion of internal inconsistency. Sometimes your motor function is quite normal. Sometimes we put the spotlight on your motor function. We draw attention to it. There's intrusion and a disturbance in motor performance. Okay, how about segregation? Abnormal crosstalk within a given network. We did find evidence of that, more modest evidence in patients with F&D versus psychiatric controls. Predominantly increased within network crosstalk for the frontal parietal network. You can see several orders of magnitude more subtle and more focused than the integration findings. I've shared with you my speculation. We need to test this. But we now have a sense that F&D may be more, at least in our cohort, of an integration problem than a problem of kind of enhanced connectivity within a given network, that notion of segregation. And I've previously alluded to our longitudinal studies. We now are approximating 40 people who have follow-up, deep phenotypic characterization, and multimodal brain imaging data. And that's going to really help us get a sense of, do these patterns of integration and segregation, are they dynamic? Do they co-vary with clinical improvement? Do they co-vary with symptom severity across 2 time points? And that will allow us to approximate the clinical relevance of some of our observations. So stay tuned, but we're not yet looking at that until the sample grows a bit more for impact. I'm looking at time. I want to make sure we have time for questions. So I'm not going to spend any detailed length discussing this task-based interoception study that's in collaboration with colleagues in the Czech Republic. I will, that's just been accepted for publication. I would just like to highlight that interoception, this notion of detecting and processing and quantifying the physiological state of our body, right? Interoception is a construct of high theoretical relevance for F&D, but it's likely a construct of high theoretical relevance for a range of conditions we see in neurology and psychiatry, including chronic pain conditions, right? So this interoception research has really taken off, and it's something that we certainly want to think more deeply about as well in F&D, including in our observations, we're finding hypoactivation of the anterior insula and the dorsal anterior cingulate during an interoception task, heartbeat counting, versus an exteroception task, counting an auditory tone. And this is in F&D versus healthy controls. Stay tuned, more to come. The paper will be out in a couple of months. Future directions. Together with Julie Maggio and Caitlin Adams, we've, in an opinion piece a few months ago, maybe about a year ago now, we've articulated this notion of brain-mind-body interface disorders, right? F&D and related conditions, but there are a lot of them, including some of the conditions I've highlighted here related to mild TBI and persistent symptoms, but also chronic pain and the notion of nosoplastic pain, which is really the new conceptual mechanistic framework for thinking about chronic pain disorders that are not driven by a structural lesion or by neuropathy, but rather by aberrant pain processing centrally. And there are many influences that we can think of cognitively, affectively, behaviorally, etc. I've not gotten to some other really great work, including work by our occupational therapists or speech and language therapists, but I really want to give a shout out to them, as well as Christina Blyer, who's doing some amazing work as a postdoc in the lab. And we've recently started thinking deeply about pathological health anxiety together with Andrew Guthrie. Christy Westland has an interest in heterogeneity and heterogeneity of brain behavior relationships. And there's a range of complexity here. Stay tuned, but a lot more to come from her on this topic. And just a big thank you. A thank you to many listening here, certainly at my own institution. Merritt, David, Brad have just been so influential in our decade-plus journey. And none of this would be possible without the F&D research group and the F&D unit, including we have fun together. And that was a picture in Verona after several glasses of wine in the bottom left slide. Thanks, everyone.
David, great job. Can you hear me?
I can, Ann.
Wonderful talk. When you, I noticed that your main approach to these patients is various kinds of therapy. And that always was the sort of approach that I just took practically as a neurologist. But you're viewing the various pathways in the brain that are being affected. And although you probably want to stay way away from pharmacologic intervention, are any of those pathways, stand out in certain particular subgroups of patients that you might attack pharmacologically?
Anne, great question. I think the short answer is we hope so, including we're really interested in thinking more deeply about clinical trials. That being said, it's a multi-pronged approach to treatment, just to kind of highlight it for a moment, right? So education is where treatment begins. And one of the things that we've articulated with brain-mind-body interface disorders is, yes, we need expert clinicians and a range of therapeutics, but the patient is an active player in their own journey of recovery. It's not a passive piece. The answer, the similar analogy would be, if you have an ovarian teratoma and an anti-NMDA receptor encephalitis, you may have a range of affective and psychotic spectrum features, right? But treatment is passive. Remove the ovarian teratoma, let's treat the autoimmune process. Buy into the diagnosis doesn't really play a big role in things. But in this whole spectrum of brain-mind-body interface disorders, it's like we're all the co-pilots, but the patient is really driving the bus. And I think that's one of the therapeutic messages that's a bit in the early phase of treatment, hard to overcome. Education, thinking about skills-based psychotherapy. Yes, physical rehabilitation, really critical. What are the physical symptoms? Brain retraining through physical rehabilitation. Treat pharmacologically the neurologic and psychiatric comorbidities. Many of these patients have chronic migraines, for example. And then what we're not approximating there at all that your question really says is, what about therapeutics, medications, neuromodulation, other interventions that specifically treat F&D? That's maybe the next decade plus. And it was a whirlwind tour de force here. I see lots of familiar faces. We're also up at the hour. Any other last minute questions? I think there's a couple in the chat. Let me just look at them. Yeah, matched for medication use. David Kaplan, astute question as always. We can look at this, but we in both of the studies that I presented, the structural and functional study. In the structural study, we looked at the influence of medication use, both antidepressants and antipsychotics. It did not influence classification. And in the resting state functional connectivity analyses, at the level of at the primary analysis, we're actually adjusting at that level for age, sex, and antidepressant medication use. So that adjustment is carried forward for all of our secondary corrections. And so essentially everything I showed you is corrected for medication adjustments as well. Okay, we'll wrap up there, but thank you all for listening, including if I've piqued your interest. please don't hesitate to reach out. I'd love to have a conversation about any and all of this. Thanks, everybody.
Thank you, David. This was extremely interesting. Have a good day.